So I will introduce Professor Zulhan Beg, who is very famous among us, especially among the radiologists who perform RFA of thyroid. So this session is about thyroidopathy, and we will begin with the first presentation of Professor Beg, RFA of papillary thyroid microcarcinoma. Welcome, Professor. Yeah.
Thank you very much for your kind introduction, Chairperson. Good afternoon, ladies and gentlemen. My name is Dr. Baek from Korea, and it is my great honor and pleasure to join this conference and discuss thyroid RF ablation. Today, I'd like to talk about radio frequency ablation of papillary microcarcinoma we call the PTMC. As we know, the standard procedure of thyroid is surgery like this. However, recently, there is paradigm shift from surgery to active surveillance because of two reasons. One is indolent nature and good prognosis of thyroid cancer, and the other is drawbacks of surgery. In 2015, American Thyroid Association recommended active surveillance rather than immediate surgery. This recommendation is based on the observational trial from Japan. So in Assam Medical Center, our hospital, started active surveillance and then published this paper. Active surveillance as a single center study. And then we published multi-center cohort study in Korea. United States also published this active surveillance paper. And 2019, our team published this data, meta-analysis of active surveillance. In this study, we evaluated tumor progression rate, size enlargement more than 3 millimeter. That was 0.1% at 1 year. However, 5.3% at 5-year follow-up. This is a size enlargement more than 3 millimeter. What about the lymph node metastasis? At 5 years, it was 1.6% at 5 years. However, there was no distant metastasis, no cancer-related death. Therefore, I would say tumor progression rate of active surveillance during 5 years is around 7%. 7. Please remember 7. So this table shows limitation of active surveillance. As we know, conversion surgery, another name is delayed surgery during active surveillance, is due to tumor progression, size enlargement, or lymph node metastasis. However, this meta-analysis shows conversion surgery during active surveillance is very high because of other lesions other than tumor progression. What is other lesions? Please imagine, what is other lesions? It is anxiety. Anxiety of patients and anxiety of their doctors. So this is the first limitation of active surveillance. Second one is active surveillance for young patients. This data shows tumor progression is much higher in young patients than older. You can see. So active surveillance for young patients is not available. This is the data of active surveillance for 5 years. Tumor progression rate is around 7%, and some patients received surgery due to anxiety, and active surveillance for young patients is not available. What about somal ablation, especially radiofrequency ablation? This is our guideline, Korean guideline, suggests RF ablation for cancers in patients with who cannot undergo surgery. After our publication, ETA and combined source group published this data, and then United States Head and Neck Society also published their guideline. We also joined in this guideline. And then European and Chinese doctors published this guideline together. So this is a summary. All RF ablation guidelines suggest RF ablation of PTMC for patients with unfit for surgery. However, these three guidelines suggest active surveillance and somal ablation can be applied to PTMC. RF ablation is recommended for low-risk PTMC. What is the definition? Here is the definition. Less than 1 centimeter, no extrathyroidal extension, and no lymph node or distant metastasis. Here is a picture of extrathyroidal extension. So RF ablation is A type of nodule is a very good candidate for RF ablation. And when the tumor is obtaining to trachea, the C is a very good candidate. And the most important thing is lymph node metastasis. How to detect lymph node metastasis? Our guideline suggests metastatic lymph node in ultrasound and CT scan. The ultrasound feature is a cystic change like this and like this, and the calcifications like this, and the increased echogenicity of lymph node like this and like this, and abnormal vascularity. These 4 features. And we recommend thyroid protocol CT scan. In 2011, our society published thyroid protocol CT like this in our prospective multicenter study, and this protocol was revised in 2021, our guideline. This table 7 shows a thyroid protocol for metastatic lymph node. Here is our website. Please join our website, because in our website we posted our imaging guideline, thyroid CT protocol, and the biopsy guidelines, and ethanol and radiofrequency guidelines here. You can download our guidelines freely in our website. Here is two CT protocol. It's a conventional and it's a thyroid protocol CT. Where is metastatic lymph node? Where? Thyroid metastatic region is a very early enhancement. So you can see the hyper-enhancing nodule inside the lymph node. You can see here and here. But what about the metastasis in conventional CT? It's not definite. So I would say only arterial pace. CT is very specific for metastatic lymph node. Another case, thyroid CT protocol and conventional CT protocol. The lymph node is more intense enhancement in thyroid CT protocol. Let's move on to the device. For small PTMC, I use relatively small active tips, 5 millimeter or 7 millimeter. In case of 5 millimeter, I use 50 watt of RF power, and the 7 millimeter, I use 30 watt of RF power. And here, you can see the bipolar electrode. In bipolar electrode, the grounding pad here is not necessary. And this electrode is very safe, even pregnant woman or patient with a pacemaker. In terms of techniques, I use moving shot technique, as you know, and sometimes I use fixed electrode technique in case of a very small thyroid cancer. Hydrodissection technique is very important for safety. When the tumor is near the carotid sheath, we can use anterolateral hydrodissection like this, and you can treat the tumor very safely. And here is a posterior approach for posteriorly located PTMC. Third technique is pretracheal injection of hydrodissection. This technique can separate the ischemic area and trachea. And sometimes I use direct injection of fluid at danger triangle. This case shows the PTMC is very close to trachea. The pretracheal hydrodissection successfully separate the tumor and trachea like this. You can see the trachea obstructing tumor, PTMC, using hydrodissection, we treated large area of ablation zone like this. And what about the 2 months follow-up? The lesion is much decreased and disappeared at 1 year follow-up. Here is 4-year imaging follow-up after RF ablation. We treated 6 cases and followed 4 years. 4 disappeared completely, 1 markedly decreased, and 1 remained as a calcified thyroid nodule. This case shows completely disappeared tumor 4 years after RF ablation. This case shows somewhat remained scar-like lesion at 4 years. We performed core needle biopsy. There was no tumor cells. And 1 year later, 5 years, this lesion was completely disappeared. Here is PTMC, hypoechoic solid area with calcification. After radiofrequency ablation, hypoechoic soft tissue is disappeared, but you can see the calcification is remained like this. Here is our publication, meta-analysis of PTMC after summer ablation, 5-year data. In this data, we invited 1 Korean data and 2 Chinese data. When you compare the active surveillance and the summer ablation, it's all 5-year follow-up. What about the tumor progression rate? Much lower. Surgery due to anxiety, much lower. Young patient, radiofrequency is available. However, as you can see, the number of studies are only 3 studies, and the patients are small. So recently, more data, 1, 2, 3, 4. 4 studies, more than 5-year follow. 5-year, 10-year. What about the tumor progression rate? Still much lower in summer ablation than active surveillance. And the surgery due to anxiety is still very low. Another advantage is applicable to young patients. Summer ablation. So I would say, in this editorial, we described RF ablation can overcome the limitations of active surveillance in terms of reducing delayed surgery due to anxiety and applicable for young patients. Please remember these 2 factors. However, what about the cost? RF ablation is high cost than active surveillance, and the quality of life is not clear so far. So this is my last slide. I explained paradigm shift from surgery to active surveillance, and then I explained the comparison of active surveillance and radiofrequency. I explained the advantages of RF ablation for treating PTMC. And many international guidelines suggest somal ablation for PTMC so far. And please remember, what is the best indication for somal ablation? It's a low-risk PTMC. Thank you very much for your attention.